Okay, so for our first case, the patient's a 45-year-old woman who's had slowly progressive left-sided leg pain down the lateral part of the left leg and over the dorsum of the left foot. She has no past medical history. Neurological exam is normal. So for some other things we'd like to know, let's see, it looks like we have Sumed. Sumed, aside from a good physical exam, is there anything we want to know evaluating a patient with left leg pain?
Yeah, I'd want to know, past surgical history. Does she have any like surgeries to her spine? I'd want to know if she has axial back pain, or is it mainly the left leg that's in the pain? Does she have radicular pain, as in it, originates from her spine and then comes down, or is it really mainly or isolated towards that lateral aspect of the leg and then the dorsum of the foot? And then I'd want to know family history. Maybe she has neurofibromatosis in her family, and that could be something where I'd be looking for a nerve sheath issue or an actual nervous issue versus, or sorry, peripheral nerve issue versus something more like a radicular pain caused by a disc, something like that.
Yeah, very good. And I think the only other thing maybe I'd mention is if there's any aggravating factors or anything that seems to make it worse. So if the MRI is unremarkable, are there any other studies you would think about getting? You mentioned maybe you'd consider a peripheral nerve or soft tissue problem. Is there anything that might help rule that out?
Yeah, you could potentially get an ultrasound of like the lower extremity, like the of the nerves. You can potentially get an MRI dedicated of the lower extremity, and then potentially an EMG. But I would probably get the imaging first before doing EMG.
Yeah, and I think that's all reasonable. You can get an EMG if you're just really not sure where it would localize.
Hmm.
And nerve conduction studies in general can be helpful in these cases. And this patient in particular, it wasn't a great study, but we did see on the left side that the peroneal nerve had prolonged latencies compared to the right side. So the next thing we did was got an MRI of the left leg, or I guess of both legs. Do you see any pathology here?
Yeah, yeah. I think I see, or I do see on the left. There's this T2 hyper intense, kind of like looks like very well circumscribed lesion, um, kind of near where the gastrocnemius is between the
Here, I've got kind
tibia
of
and fibula.
just a
Nice.
refresher here because we don't look at these MRIs every day. So kind of in that general area, you're basically looking at the back part of the top of the right leg in this picture, and so you can see kind of tucked in underneath the gluteus maximus is where the sciatic nerve bundle is. So knowing that, what do you think we're looking at?
Yeah, and it looks like they a well circumscribed lesion, originating from that potentially sciatic nerve bundle, or maybe like lateral to.
Yeah. There's a contrast enhancing lesion there. It looks like it's got bright T2 signal. I think we covered that.
Josh, it might be helpful if you go back to the other MRI and just show us the normal sciatic nerve.
Yeah.
No, the others.
On the other side.
Yeah, they have the right
Yeah.
and the left.
Right. So
On
the normal sciatic nerve, I'm not sure if you guys can see my mouse, but would be right here.
but better seen on the T2 weighted image.
Right
Yeah,
here.
there, and you can actually see the two divisions, the tibial and the peroneal component. The tibial is a little bigger. And in terms of location, obviously this is the upper leg, but in terms of approach, you can see the gluteus maximus, as the most superficial, and you're right at the tail end of the gluteus maximus. So, in terms of approach, you're thinking either a subgluteal, meaning you lift the gluteus maximus up, and that's probably the most easiest way to get to it, or sometimes you go transgluteal if it's higher up.
Yeah, and I think for this case, because it was higher up, they did go transgluteal. Okay, so I think we have Kat Berry logged in. Kat, what would the differential be for this lesion?
Good morning. So you could have a benign peripheral nerve sheath tumor, just because there's no weakness. That would be the top of my differential.
Good, and those
have
the main two would be
Yeah,
which?
but malignant and benign peripheral nerve sheath tumor or
Right.
neuroma.
Right. So there's a couple types of benign nerve sheath tumors that we would see peripheral.
Oh, I see Schwannoma or like a neurofibromatosis neuroma.
Yep, definitely. So far and away, those two would be the most likely. And then you mentioned NF, and NF you consider plexiform, but we know from the imaging this looks to be pretty well circumscribed. And then the malignant peripheral nerve sheath tumor would also be in the differential. For in terms of treatment, what would your goal to treating this be in the first operation?
Since she's symptomatic, I think the goal would be to resect it. If it's benign or has benign features on frozen, you would want to preserve the nerve over complete resection.
Yeah,
but
definitely. It's a benign, most likely a benign tumor. Based on the imaging, it's probably Schwannoma or neurofibroma. So the goal would be to take it out, and I'll let Dr. Kultekin take over.
Yeah. Can you move the slide? Yeah, so this, as you can see here, on low power, looks like a very well circumscribed lesion. You can see next to the arrow there, pink area of a capsule that surrounds the lesion. And I don't know if you don't see my arrow, do you? Let's see.
We do not.
Yeah, but there's a big capsule around. Yeah, there, that one. Okay, that's important because the truly encapsulated one big lesion that is truly encapsulated is Schwannoma. So from that alone, you can kind of surmise that this is probably going to be a Schwannoma. And can you move to the next slide, please? So as you can see, this is a trichrome stain, Masson trichrome, and the blue represents collagen. The capsule is blue, and when you look at the tumor itself, it looks like it's composed of denser and looser areas, and the blue is kind of creeping into the parenchyma of the tumor. Sometimes this happens in peripheral schwannomas that you can see a lot of collagen within the tumor as well. Next. So as far as the cellularity goes, as I said, there's a biphasic appearance. The cloud-like wider area in the left center is more of a Anthony B type area, and then the other areas in the upper center are more of a Anthony A like areas. And in the periphery, you just showed the inflammation, the blue, dark blue part on, yes, exactly. And there's a lot of inflammation in the tumor, which is not uncommon for schwannomas. Next, please. In this case, there's a ton of inflammation, especially plasma cells. This, you're looking at an area here, which is 90% inflammation and 10% collagen. So this schwannoma was interesting that way, that was really a huge amount of inflammation in certain parts of the tumor. Next. And SOX10 is a nuclear marker that labels schwannomas, at a very high percentage. And it's a reliable marker of peripheral nerve differentiation as well as melanocytic, but in this case, and SOX10 is negative in meningiomas. Next. S100 protein is a well-known, trusted old marker of peripheral, Schwann cells, and this is positive unequivocally. Nuclear and cytoplasmic, and the blue parts that you see in the upper left are the inflammatory parts, which shouldn't stain. Next. Collagen type 4 shows here in the left, the denser part is Anthony A, that the looser part on the right is Anthony B, and collagen 4 represents here the basement membrane that Schwann cells are known to bear, as opposed to some other cells. So for pathologists, if you demonstrate basement membrane in this setting, it's a good sign that you're dealing with a schwannoma. That's all I have.
Yeah, so just a couple things to remember about schwannoma. It's the most common nerve sheath tumor that we encounter, although relatively rare in the lower extremities, accounting for only about 8% of all schwannomas. If you see more than one, it's likely the patient has NF2. And just, sorry?
Interrupt you there. That's not correct. So if someone has a schwannoma isolated, it's probably isolated. They don't have NF2. If they have multiple schwannomas, true schwannomas, not neurofibromas, then they probably have schwannomatosis. Schwannomas in NF2, they can happen, but they're very uncommon. I mean, they usually have neurofibromas, and I'm sure Dr. Gultekin can, tell you the difference histologically between the two. So if multiple, it's likely schwannomatosis, not NF2.
Thank you.
Yeah. I need to add something here. Are you going to talk about schwannomatosis at all?
No.
Okay, because Dr. Levy is of course 100% correct, and I want to remind that NF2 of course has NF2 as opposed to NF1. There's a genetic background. In the NF1 it's 17, chromosome 17. In NF2 it's chromosome 22, and two different proteins. But in schwannomatosis, the gene is called SMARCB1, which is a tumor suppressor gene that regulates cell cycle growth and differentiation. So these are completely different diseases, and when you see schwannoma, of course, bilateral acoustic neuroma, tells you that there's a possibility of NF2, but I think we should learn how to think about schwannomatosis as an underlying genetic disease in these cases, okay?
Yeah, definitely. And that's I listed the diagnostic criteria here for NF2 as well. And, obviously the big thing being if you have a first degree relative, and then one of the other tumors that are diagnostic being meningioma, schwannoma, glioma, or lens opacity. And I had, there was one other slide here. Huh, it must have gotten deleted. Okay. Okay, moving on to case 2. In this case, it's a 16-year-old boy who presented with chronic headaches and an acute onset right abducens palsy, past medical history of ADHD. On physical exam, unremarkable except for diplopia with a right horizontal gaze. So neuroimaging is shown here. Let's see. Can Eva Wu describe what we're looking at here?
Hey, Josh, can you hear me? Eva is doing a lumbar drain for an ENT case. So maybe somebody else could help. Sorry.
Yeah, no problem. All right, let's see. I think we have Dan Eichberg.
Can you hear me?
Yeah.
Okay. Sorry, I was just getting my next presentation ready. So you're asking the differential?
Yeah, or just if you want to kind of describe what we're looking at.
So this is sort of a heterogeneously enhancing lesion that's focused sort of in the parastellar area that's also involving having some bony involvement. The clivus looks like it's a little bit moth-eaten. No hydrocephalus. It looks like it's kind of eroding through the different tissue planes. I guess involving the nasal cavity a bit as well.
Right. So it's the lesion looks like it's mostly centered within the sphenoid sinus, which you'd said erodes the cell on the planum, and extends into the nasopharynx and also the retroclavial space. The differential for this tumor in a young boy like this, at the top you'd have a JNA, and then in older patients you would think about esthesio or angioma, or maybe some type of carcinoma. And Dan, as a tumor expert, what would the preferred surgical approach be for that tumor?
So I think the primary initial goal at least is to obtain tissue for diagnosis, because the management can be different for those different entities. But I would probably favor a endoscopic endonasal approach to at least get tissue and unfrozen and see what it is, and then kind of define the plan from there.
Yeah, definitely. And I think that this patient in particular had undergone a biopsy at another hospital first that was inconclusive. And then, the other thing to think about with a tumor like this, if you have something like JNA on the differential and you suspect it's going to be a very vascular bloody tumor, you could think about an angiogram beforehand and possibly embolizing. So in this case, they did do a endonasal approach, and I'll let Dr. Gultekin go over the path here.
So this was handled by ENT pathologists, and their diagnosis is angiomatosis. And next, please. Yeah, so you can see here, there's a lot of course, blood and some hyalinized pink, light pink looking spaces where, it's really difficult to understand what exactly this is from a low power. Very sneaky lesion here. It looks like a bunch of blood and fibrin. So let's see what it is. Next slide, please. So essentially, to cut to the chase, when you do markers of endothelium, all of a sudden, in this mess that I showed you before, you start realizing that there is a background of capillaries. In the inset, you can see it better that these are actually endothelial cells that are variably surrounding vascular spaces. So this is a sort of a benign infiltrative entity that's called angiomatosis and frequently seen in the head and neck region. So that's all I have for histology.
All right, thanks, Dr. Gultek. And so, it's angiomatosis of the head and neck is a pretty rare tumor, at least for us to encounter. They can happen anywhere in the body, and it's essentially a disease. It's considered to be a disease of childhood. The lesions are benign, and they're often mistaken for hemangioma or an AVM, but they do have a very high risk of occurrence, and they're frequently symptomatic because they can get very large. A couple key points. They're distinguished from an AVM by having other mesenchymal components within the lesion tissue. And they usually involve multiple tissue types, so it will span across bone, cartilage, fat, which we saw in that patient. And there's not a lot in the literature about this. There's most comprehensive study I found was an older study that essentially looked at 51 patients who had this. You can see most of the lesions were involving the lower extremity or the trunk. Most had recurrence, and the vast majority were in patients under the age of 30. So anyway, interesting case.
I guess the surgical point is that it's difficult to remove these completely, especially from the head and neck region. That's why they recur. And there's frequently associated adipose tissue, which you may have seen during surgery. I don't know.
Yeah, hi, Josh, can you hear me?
Yes.
Yeah, we were very aggressive with the resection. It wasn't particularly difficult. It just unusual look. It's inside the bone, and we kept drilling till we got normal bone margins. Have you come across in the literature review whether beta blockers, similar to what sometimes is used for cavernous angiomas in kids, that can make them regress, particularly in the cavernous sinus? Have you come across the use of it in this entity? I haven't reviewed the literature myself.
No, I didn't, when I was reviewing, didn't come across any type of medical therapy that was being used for it, though I had considered that, obviously, because people have used, various inhibitors for AVMs, for instance. So it'd be interesting to know if that could be helpful. Although I'm not sure that they know what really drives this kind of vascular proliferative process in these tumors.
Yeah. Well, we have no choice but to just follow him right now with periodic scans.
All right. Thank you. For our next case, this is a 32-year-old woman who's had an incidentally discovered brain lesion. It's been followed for about 15 years now, who's had a sudden worsening of her headaches. It's different in character from the migraines that she usually has. On exam, she's neurologically normal, and her imaging is shown here. We have Victor Liu.
Yeah, hi Josh.
Hey, Victor, can you tell us what you see here? I think we may have lost Victor. I'll bump this one up to another oncology expert, Dr. Luther. Can you describe the imaging here?
Hey, Josh. Yes, this is a non-enhancing lesion within the right lateral ventricle centered around the foramen of Monroe. Looks like on the coronal slice here that there's some evidence of ventricular dilation or obstructive hydrocephalus in that right ventricle.
Yeah, definitely. So possibly early hydrocephalus and a lesion in the foramen of Monroe. I think we covered that. Some deviation of the septum pellucidum. So differential for tumor in this location would be fairly broad.
Which room is it?
So, a few things. Non-enhancing lesion in the ventricle, one thing to consider would be a subependymoma. Based on appearance, central neurocytoma, less likely, but nevertheless, tumor in the lateral ventricle, that would be on the differential. SEGA, if the patient had tuberous sclerosis. Colloid cyst, which is probably most likely just based on imaging alone, and then also meningioma and choroid plexus papilloma would be on the differential here, although there really wasn't any enhancement, so those would be less likely. And if it were a child, of course, ependymoma. So in terms of management, Evan, what are our kind of options for accessing this tumor?
Sure. I mean, I think in general, this area, the two options are either interhemispheric transcallosal or transcortical using like a tubular retraction system.
Right. And then, just kind of in terms of counseling the patient, you're working around the foramen of Monroe, you can also keep in mind that they may have some short-term memory, at least kind of in the acute post-op period, wouldn't be uncommon. We covered all of that. Okay, great. And I'll give it back to Dr. Gultekin.
Yeah, so if you could kindly move the slide for me. None of those differentials somehow proved to be the case, interestingly, and from morphology, it's very easy for a pathologist to rule out all those entities, SEGA, meningioma, choroid plexus papilloma, subependymoma. It's none of those, interestingly. Although I'm not shocked, that this turned out to be a pilocytic astrocytoma, the enhancement properties may be a little interesting, but overall, we see a glial proliferation, and the nuclei look low grade or, on the benign side. Next. So there are areas that look almost like an oligodendroglioma, and this is a known phenomenon in certain pilocytic astrocytomas. You can see round cells and delicate blood vessels that may give you the false impression that you may be dealing with an oligodendroglioma, but this was focal. Next. And these are, there's an area where this is more like a pilocytic astrocytoma, cells with multiple nuclei at the bottom of the center. There is one, they used to call these pennies on a plate at the bottom. Yeah, like 3 or 4 nuclei in a cell. Yes, you're getting closer. Anyway, and then there are, of course, Rosenthal fibers, these pink structures that are sort of elongated pink structures that are hallmarks of pilocytic astrocytoma, among others. There's a very definitive fibrillary background with glial cells and looser areas and denser areas. Next. GFAP is positive in the looser areas and denser areas alike. Next. This is glial fibrillary acidic protein, a marker of glial cells. And Ki67 is very low, around maybe 1% or less. At the time of finalizing the pathology report, the BRAF molecular study was pending. I'm not sure if you're aware of the result. I'm not.
No, I didn't see that in the.
Yeah,
in the
it's been like, I think, 3 weeks since it was reported, meaning the actual pathology report was finalized. So I assume it has to be back. I didn't see any addenda that reflect that in the report. So anyway, it's a midline tumor. We did HT K27M. It was negative. Overall, it looks like a grade 1 tumor. Was there total resection?
There was on this case.
Okay.
Yeah, so certainly interesting case, like Dr. Gultekin mentioned, just based on imaging alone and kind of the patient's demographics, not what we would have expected. But just to review, usually we see pilocytic astrocytoma in younger patients or in children. And the typical radiographic appearance is a cystic nodule that enhances. And as it is a grade 1 tumor, the overall survival is really good in these patients with a complete resection. And then the most common location, usually in children, is within the cerebellum, but they can also occur along the optic pathway in NF1, and they can also commonly be in the hypothalamus. I did find there were a few reports in the literature of very similar tumors, actually. There's this one paper in particular from about 5 years ago where they looked only at pilocytic astrocytoma within the lateral ventricles. And those actually occurred predominantly in older patients and tended not to enhance. And you can see that's an MRI from that study, which is very, very similar to what we saw in our patient, just on the contralateral side. So just something to keep in mind with these patients. And we'll move on now to our last case. So this one is a 31-year-old man with a history of seizure and headaches. The physical exam is unremarkable, but he's had the seizures now for years, and it's been difficult to control with medication. He wants to know what his other options are. So he comes into the office with this imaging. Do we have Vignesh?
Yep, I'm here.
Awesome, Vignesh. Can you describe these MRIs?
Yeah, for sure. So we have on the left we have a T2. Oh, sorry. On the left we have a T2 image that looks like has some hyperintensity along the anterior temporal lobe. And on the far right, it's a flare signal image with some flare hyperintensity. The middle is, I think, a T1 with contrast, and doesn't look like there's much contrast enhancement there.
Yeah, excellent. That's exactly what we're looking at. So based on that, can you name a few things that could be?
So I think my highest on the differential would probably be a low-grade glioma. And then I would, guess, yeah, I think probably low-grade glioma would be like highest on the differential.
Good. Yeah. So, there's a few types of low-grade glioma that this could be, and in particular when you're talking about temporal lobe seizures, especially in younger people, like for the boards, the big one is DNET, and that's one we see a lot, kind of in the pediatric population as well. But based on the appearance, it could really be any of these low-grade tumors. I didn't see a CT in the chart, but if there were a CT and that showed calcification, that could also kind of tip you off towards oligo or oligoastro.
Mm-hmm.
And then a PXA would usually have more of a cystic component to it, which we didn't see there. And then pilocytic astrocytoma, same thing. So the surgical considerations here, I'll just kind of go through because they're fairly nuanced, and I'm not going to go too much into detail on this, but it's in a patient like this, you've got two goals with surgery. Basically, you want to cure their oncologic disease, and you want to cure their epilepsy. So what's the best way to go about that? And the answer to it is that there's not really a consensus. You could do a focused lesionectomy if you think it's a low-grade tumor and see if that cures the seizures, or if you think it might be a higher grade tumor, or if the patient has long-standing seizures, who's had a previous surgery, or involvement in the mesial structures. Those are all factors that could make an argument more for doing a anterior temporal lobectomy. And in this case, a lobectomy is what was done. I'm not sure what's going on with this. There we go.
Does the hemispheric dominance affect surgical decision here?
It can. It usually will if if you need to extend the resection further posterior. Kind of taking the tip of the anterior tip of the temporal lobe on the dominant side is generally safe. But if you're going to go further back, then I think it's about 5 centimeters or so, then you definitely want to do language testing preoperatively.
Okay, thank you.
Sure. Sorry, the slides kind of got mixed together there, Dr. Gultekin, but I'm on to your slides now, I believe.
Yeah, so Dr. Saad looked at this case and he shared it with me as well. And he called it a low-grade glioneuronal tumor. I put the NOS myself, not otherwise specified, because I want to make a point about calling something low-grade glioneuronal tumor. When we give you that title as a diagnosis, this is not a specific entity. This is rather like an umbrella term that includes a lot of different entities, gangliogliomas, sometimes PXAs, And the entities that I'm enumerating below, ganglion cell tumors, gangliocytomas, etc. So that means that the pathologist isn't able to decide which one of these tumors, and of course the list. In this case, this differential diagnosis is more specific. What I'm saying is the use of the term connotes, many more entities. It just tells you that this is not a diffuse infiltrative glioma. Okay, so I think we should kind of agree on or be on the same page in the terminology. Having said that, in this particular case, why don't we go to the histology first? So first of all, it seemed well circumscribed from the surrounding parenchyma in general. Okay, and on the left side, you can see the tumor proper. It's composed of rather small round cells, which are trying to make rosette-like formations, and not much in between. The vascularity is delicate. There are no mitoses. There's no necrosis. It looks like a really low-grade tumor. Next. Again, you can see here the tendency for kind of circling around neuropil, forming rosettes on the right side, even surrounding blood vessels, trying to make rosettes, and overall the low-grade histology of the nuclei involved. Next. Under real high power, you can see that some cells are round, some cells are more elongated. There are some nuclear membrane irregularities in certain, cells with some notching, etc. But overall, again, a benign histology. Next. It was strongly positive with neuronal markers. This is synaptophysin. It's a synaptic protein, calcium binding protein, very strongly positive, except the blood vessels, as you can see. Next. Interestingly, in immunohistochemistry, we have a BRAF VE1 reagent, which is kind of a preliminary test before the molecular testing, but in this case, it was positive. So this is a BRAF mutated lesion, very important for therapeutic, decisions, especially if the tumor recurs or if there is residual tumor after surgery. Next. So it was CD34 positive, OLIC2 positive, HU is another early neuronal marker positive, and GFAP was kind of if you look at the center, it's more blue. It was negative in most tumor cells, so maybe focally positive in some. At best, focally positive. I think it's more negative. So neuronal differentiation demonstrated by immunohistochemistry, low-grade histology, and BRAF positivity makes this a good candidate for a low-grade glioneuronal tumor. Could be a rosette-forming glioneuronal tumor, which is supposed to have FGFR mutation and some others. So that's it for histology. I don't know if the NGS is back on this. Are you aware of any NGS or any other studies? KI was very low.
Yeah, and I didn't see that.
Okay.
FGS back in. For glioneuronal tumors, I just listed here those that are the most common and that we commonly see. There's some features of each of these that were present in this tumor, and then some notable features that were not. but papillary glioneuronal tumor, radiographically could look like this tumor. Those would be positive for GFAP. This tumor was not. Desmoplastic infantile glioma looks very different from this tumor, and is usually just only in patients in their first year of life. It's a large cystic hemispheric tumor. DNET can also look like this, and like I mentioned earlier, often does present with seizure. And the buzzword for DNET is a glioneuronal element, which is kind of this appearance of floating neurons in a myxoid matrix, which we also didn't see in this case. Ganglioglioma can also present with temporal lobe epilepsy. It's another low-grade tumor, but has some other features that we didn't see here. And then the rosette-forming glioneuronal tumor, the fourth ventricle, is obviously located within the fourth ventricle and presents more like the other posterior fossa masses of childhood.
Josh, would you allow me to do a quick comment?
Yeah, of course.
Here. Let me correct something before. First of all, there's no plastic infantile ganglioglioma. It should be. It's not infantile glioma. It should be ganglioglioma, number one. Number two, rosette-forming glioneuronal tumor is now proven to occur outside fourth ventricular location. And one of the biggest proofs is that there is a common denominator molecular alteration, FGFR mutations, fibroblast growth factor 1 mutations in these tumors, similar morphology, identical molecular alteration, and not in the fourth ventricular location. And so that means that we cannot rule this out just based on location anymore. So the name has to be changed. Okay, so that was the second one.
Definitely, thank you. That's very interesting.
Josh, could I do a quick comment?
Sure.
It's Joe Gracioli. It was a very good question from Dr. Gautekin regarding dominance. So typically we do a functional MRI to determine what side is the language dominance is. And then the 5 centimeters you were referring, I think it was more related to not to enter the Mayer's loop to avoid the superior quadrantopsy on the other side. But when you were talking about language, usually we have language even before the 5 centimeters limit in the superior temporal gyrus. Therefore, sometimes even we can stratify and tailor the resection, preserving more from the superior temporal gyrus, and then going maybe even posterior in the middle and inferior one.
Okay, well, thank you, Josh. I'm just going to share my screen here. Okay, can everybody see my screen and hear me?
Yes.
Okay, great. Okay, so we're going to get started because we have a lot of content to talk about. So we're going to talk about a critically important topic that's often neglected in medical education, which is personal finance for neurosurgery residents. I'm calling this a guide to financial wellness. So first, some disclosures. I have no conflicts of interest. I'm not a financial planner or financial professional. In my past life, I was never these things either. I'm just someone who's read a lot about these topics. And finally, this is not financial advice. This is only for general educational purposes. So everyone's financial situations are different, and I haven't considered your specific financial situations. So we're going to start with a quote that is really phenomenal, which is, "The best time to plant a tree was 20 years ago. The next best time to plant a tree is now." And I'd like you to keep that in the back of your minds throughout this entire presentation and really think about what that quote means. So who goes bankrupt? Well, the first group of people that comes to my mind for going bankrupt are lottery ticket winners. Lottery ticket winners apparently go bankrupt at twice the rate of the general population. Now, how is that? How do you give somebody millions of dollars and then actually increase their risk of going bankrupt? Well, maybe it's because they don't have dedication. They don't have the dedication to save and be responsible. But I don't think that's the answer, because pro athletes also go bankrupt. And these people have extremely high levels of dedication. They wake up every day at 4 a.m. and do practice, despite having huge net wealth. So Mike Tyson had a $400 million net worth and he went bankrupt. How is that possible? 15.7% of NFL players go bankrupt 12 years after retirement. That's wild. So almost 20% of professional football players go bankrupt. And maybe it's because professional athletes don't have as many years of formal schooling, but that isn't the case either, because doctors go bankrupt as well. This became very famous during the COVID pandemic because a lot of elective surgery practices closed down. A lot of primary care clinics also closed. But to be honest, this has been a problem for much longer than the pandemic. Back in 2012, 2013, the news was reporting on physicians going bankrupt. So what's the same about doctors, professional athletes, and lottery ticket winners? What puts all of them together? I think the answer is that none of them have good plans. So you take somebody who doesn't have very much money, when you're a resident, you're working very hard and you're not getting paid very much. And then one day you suddenly give them a huge amount of money. And if you don't have a plan, it's very easy to lose all that money. So before you laugh at Mike Tyson and the professional athletes and lottery ticket winners, ask yourself this question: what will happen to you when your paycheck gets an extra zero once you graduate? And you have to arm yourself with knowledge. And this is because the financial world understands that doctors have a target on their backs. They know that doctors are bad with money, that they're not financially literate, and they will take advantage of you if you let them. Those who fail to plan to fail. This is true of everything in life. It's certainly true in the operating room. If you go in the operating room and you don't have a plan, you're going to have a bad day. And even worse, the patient's going to have a bad day. So the purpose of this lecture is not how to teach you how to have a larger boat or fancier clothes. It's really about improving your emotional wellness and financial wellness, because I think that if physicians are not worrying about money, meaning not on the brink of bankruptcy and running away from creditors, is it possible that they have fewer potential conflicts of interest when planning treatment? Is it possible that they have a lower burnout rate so they're able to take care of more patients over their entire career? Is it possible that they are more focused on patient care and less distracted, unlike the stock market? I think the answer to these questions is yes. So the goals of this talk is I want to hammer home the point that personal finance is easy. It's not neurosurgery. You can do this. You can learn this. I want to tell you that you should take charge of your finances right now. Don't put it off. Plant the tree today. A simple and automated plan is the best. You want to set it and forget it, just like this infomercial phrase. And then finally, I'm going to teach you how to make SMART goals in order to take your financial plan from theory into practice. So what's the ultimate goal of personal finance? You can't have a plan unless you have a goal. So the first thing is to establish the goal. The goal is you want to achieve something called financial independence. And this is when your nest egg, which is another name for your collection of investments, pays your income. So you want to have enough investments that it's able to grow in size to keep up with inflation and cover all of your expenses. It's the ability to live off your income from investments without touching the principal of the nest egg. You're able to pay for all of your living expenses through your investments, and you're able to keep enough gains left each year in order to keep up with inflation. So I made this cartoon because I want to sort of explain the importance of being humble at this point in our financial situations. So this is comparing your net worth to height above sea level. So net worth is calculated as your assets minus your debts. So a lot of residents think that they're somewhere up here on Mount Everest in the positive net worth category, but really if you have student loans, you're somewhere down here in the Mariana Trench. This puppy who's floating at sea level actually has greater net worth than you if you have student loans. So that's just something to be mindful of and be humble. And it also speaks to the point that once you reach zero net worth, that's actually something to celebrate, and it's a huge accomplishment. So keep that in mind. So how do you calculate your net worth? You really should only count your income producing assets. So this is specifically a number in a brokerage account. Okay, this is your stocks and your bonds. It can also be real estate investments, but I think most residents probably shouldn't be landlords. So I'm going to focus on stocks and bonds. It shouldn't be your car. It shouldn't be your clothes, because these things don't pay you to own them. And when you see people driving around fancy cars, it's important to remember that the owner of $1 million car isn't necessarily a wealthy person. They're just someone that's spent $1 million. A real millionaire has $1 million or more in their brokerage account. So how much net worth do you need for retirement in order to build your nest egg that you're able to live off of? Well, there's really two methods. Method one is favored by most people, which is you save money here and there, and you hope you have enough money when you retire. That sounds like a plan for failure. The other way to think about it is you want 25 times your annual spending. And when you have 25 times your annual spending, then you've reached financial independence. So where does this number 25 times your annual spending come from? It comes from a landmark study called the Trinity study. And what they did was they looked at different asset ratios. They looked at different amounts of stocks and bonds, and they looked at the performance over several different 40-year time periods historically. And they also looked at the percentage of money that was withdrawn from the accounts every year. And what they found was that if you have a 50-50 stock bond portfolio and you withdraw 4% of that money every year during a 30-year retirement period, you have a 96% chance of succeeding during retirement, meaning that you don't run out of money. There's a 4% chance of failing, which means that you have $0 at the end of the 30-year hypothetical retirement period. But interestingly, there was a 67% chance of doubling your net worth at the end of the 30-year retirement period. So they concluded that 4% is sort of the safe maximum amount of money that you're able to withdraw per year. And a lot of different financial experts will argue over the specific numbers. So some people think that you should be withdrawing more than 4%, less than 4%. Some people say that you should be saving more than 25 times your annual spending. Some people say you should be saving less. But the overall concept everyone agrees on is that there is some number with which you can live off of the gains from the investments. And you can also keep in mind that you can be flexible during retirement. So if the stock market does poorly, you can adjust your spending accordingly. And then finally, to really lose all of your money, 3 things have to happen. You have to live for a lot longer than you think. You have to have bad stock market returns during several key years during retirement. And you have to have very high withdrawal rates. So it's relatively unlikely that all 3 of those things will happen. What if all this stuff is giving you a headache? Can't you just pay somebody to deal with it for you? I wish that was the case, but I think for most residents, that's not the best solution. Finding a good financial planner takes the same amount of time as learning personal finance. I would say it takes 10 hours to learn personal finance. It takes 10 hours to find a good financial planner that won't rip you off. So if it takes the same amount of time, just learn to do it yourself. Good advice is expensive. A good financial planner costs about $1,000 to $10,000 per year. However, bad financial advice is actually more expensive than good advice. And the reason is because that planners offering you free advice for financial planning are typically secretly commission-based insurance salesmen. So they may get you in with free financial planning advice, but they really want to sell you inappropriate insurance products. So that's sort of the best case scenario, is that you may have a conflict of interest with your financial planner. And in the worst case, they could actually be stealing from you, like in the case of Bernie Madoff. So what if you do want to have a financial planner, despite what I just said? I really don't think that you need one for the wealth building phase, which is when you're accumulating your nest egg, or the wealth maintaining phase, which is when you're maintaining your nest egg, but you're still working. It could possibly be useful to have one during the wealth distribution phase, meaning once you've actually retired and you stop working, there are some complicated tax issues, and it could be helpful to have a financial planner help you with this. But that's going to be 30 to 40 years from now, so you don't have to worry about that right now. If you're going to have a financial planner, you need to have a signed fiduciary agreement with them. So a fiduciary agreement means that they are legally obliged to work in your best interest. It's sort of like the Hippocratic Oath for financial planners. So you wouldn't see a doctor that hasn't taken the Hippocratic Oath. You wouldn't see a financial planner that hasn't signed a fiduciary agreement. You have to know the financial planner's conflicts of interest and how they get paid. So if they get paid commissions for products that they sell you, they have a conflict of interest and they don't have your best interests at heart. So typically a flat rate is best because then you're just simply paying them money in exchange for financial planning. So one reason that residents don't get involved with taking charge of their finances is there's a lot of tasks and it can be very overwhelming and you don't know where to start and you end up just doing nothing at all. So here are a list of all the tasks you have to take care of. It's overwhelming, but I kind of broke this up into different categories and we'll go through each one. Budgeting, insurance, having an emergency fund, paying off high interest debt, paying off your student loans, and investing. And everybody wants to talk about investing first. Investing is the most captivating. However, until you get all of these other financial ducks in a row, you really shouldn't even be focusing on investing. You need to take care of the other things first. We will talk about investing today, I promise, but not yet. So first, we're going to talk about budgeting. And I want to start with a great quote from Albert Einstein. And everybody knows the first half of this quote. The first half is that compound interest is the most powerful force in the universe. Those who understand it earn it. So everyone knows that if you put a small amount of money and it compounds continuously every year, eventually it'll be worth a huge amount of money. But people don't know the other half of that quote. Those who don't understand compound interest pay it. And the way that I choose to interpret that is when you pay fees, taxes, and unintentional spending, those things compound too. So when you take control over fees, taxes, and unintentional spending, it can literally save you millions of dollars over your investing career. Ben Franklin said, "A penny saved is a penny earned." And I humbly disagree with him. The reason for that is because of taxes. So this is what a dollar looks like that has been saved. This is what a dollar looks like that has been earned after taxes. So the reason I'm showing this is just because people don't want to worry about having a budget, but you really get more bang for your buck when you are limiting spending as opposed to putting the extra work and working additional hours. So budgeting, as I said, is the least captivating. Nobody wants to focus on it, but it's actually the most lucrative, so you should focus on it. The key to budgeting is you want to spend less than you earn. If you're not spending less than you earn, you're not saving money to build wealth, and that's a problem. You need to view each dollar that you own as an employee, and you need to give each employee a job. You can't just have your employees sitting around doing nothing. Budgeting enables intentional spending. So I'm not trying to tell you that you shouldn't go on vacation, you shouldn't have a nice life with nice things. I'm just telling you that you want to identify your financial priorities in life and put your money towards those goals. You can for sure plan for fun spending. And if you budget for fun spending, you're able to spend without guilt because that was part of your budget. Some great software tools that you can use to help you budget are, some people just use Excel. You can use mint.com, which is a free online resource. And then You Need a Budget, or YNAB, is also a great resource. It has a low fee every year, but it's probably a little bit more, has more functionality than Mint. The key to budgeting is to pay yourself first. So what do I mean by that? I mean, you want to take at minimum 20% of your gross take-home pay and automatically build it before you spend anything else to build net worth, which means either paying off debt or investing. You might think, well, I'm not making a whole lot of money now. Is it worth it? I'm going to be making so much more money as an attending. But that's not the right way to think about it. You want to build responsible habits now as a resident so that it'll be very natural when you're an attending. The first several big attending paychecks that you make have the longest to compound, so you want to hit the ground running with financial planning and budgeting. And finally, short-term saving towards non-retirement goals does not count towards paying yourself. So if you're saving for a vacation or a big birthday present for someone, that doesn't count towards building wealth. It's only paying off debt or investing. One way to think about reaching financial independence is that having a higher savings rate enables you to reach financial goals faster. So this table was made from a financial calculator that was on a blog, Mr. Money Mustache, that I enjoy and recommend. It has a few different very conservative assumptions, including that you can earn 5% investment returns after inflation during your saving years. This is conservative. It's at least historically 8 to 10% is more reasonable, but 5%, that's fine. You'll also live off the 4% safe withdrawal rate that we talked about a few slides ago. And you want your principal to last forever, and you'll only be touching the gains. So if you look at this chart, you'll see that if you save 20% every year, it'll take 37 years for you to reach financial independence. But if you increase that savings rate to 25%, you actually shave 5 years off of the time it takes to reach financial independence. So, and that effect continues the higher you increase your savings rate. So I'm not telling you to stop working early. You know, as neurosurgeons, we are very fortunate that we have an extremely fun job. We help a lot of people. We spend a lot of time getting to where we are in our careers. I'm not saying stop working early. What I am saying is that reaching financial independence earlier on in your career can be very useful for your psychological well-being. We never know what the future holds. We don't know if the government will stop reimbursing medicine as well as it does now. We don't know if you'll become disabled. If you reach financial independence, you don't have to worry about those things ever again because your investments will take care of you. Live like a resident for 3 to 5 years after you graduate. So this is tough, a tough pill to swallow because you've been working hard for 7 years. You want to buy a nice car, buy a big house, but you should be living like a resident for at least as long as you have student loans. You want to slowly build up what some people call lifestyle creep. Other people call that the hedonistic treadmill. And the idea is that, let's say that you drive a Toyota Camry that's missing a hubcap, like I do. If you buy a brand new Toyota Camry, then that seems like a luxury car at first, but eventually it just becomes your car. And then you buy a Lexus, and that seems like a luxury car, but then you get used to it and it just becomes your car. And then you buy a Porsche, and so on. And I'm not saying that that's bad. You know, you should have nice things in life for sure. I'm just saying that you should be aware of that process, that's just a facet of human psychology, and just slow it down. And you may want to slow it down until several years after you graduate. Keep in mind that you are very behind your non-physician peers in terms of saving. So if you have friends that went into finance or business or some other field instead of medicine, they've been saving money and working every year since college. So for 10 years, they've been saving money and investing. They've been building responsible financial habits. So you are far behind them. I'm just saying that in order to encourage you to, your competitive spirit to try to catch up with them. And then keep in mind that, as I said, the money that's saved during the first few big attending paychecks has the longest amount of time to compound. So you really want to live like a resident at first. So moving on from budgeting, we're going to talk about insurance. So disability insurance is by far the most insurance that you need as a resident. You're 7 times more likely to become disabled than to die during your career. You must protect your most valuable asset, which is your future income stream. People want to know, when should I buy disability insurance? And the best time to buy it is right before you become disabled. However, since we have no idea when that will be, you should just buy it right now. You want to lock in the lowest rate with the smallest policy as a resident, and then once you're an attending and your paycheck increases, you can increase your policy size. Keep in mind that you will never be younger or healthier than you are today, so you'll be able to lock in the lowest rate today. And then finally, for women, it's important to buy disability insurance if you're planning on becoming pregnant, before you become pregnant. And this is completely unfair, and they should really make a law that prevents insurance companies from doing this, but it's unfortunately the reality that we live in currently. Temporary pregnancy comorbidities like gestational diabetes, gestational hypertension are considered by insurance companies to be permanent conditions. So even if they resolve after pregnancy, they're considered to be permanent medical comorbidities, and your policy becomes more expensive. So you want to buy disability insurance before you become pregnant. What kind of disability insurance should you buy? You want to buy own occupation specialty specific disability insurance. So Jackson offers you $50,000 of disability insurance, but you have to read the fine print. If you become so disabled that you can't be a medical resident, the policy pays off. But if, for example, you lose the ability to use your hands and you can't be a neurosurgeon, but you can still be a medical resident and take care of people in the diabetes ward, your policy does not pay you. So you want a policy that pays you if you can't do your job as a neurosurgeon. I have a picture here of a neuroradiologist, because with these policies, even if you can't work as a neurosurgeon, they'll still pay you even if you are working in a related field that's outside of neurosurgery. So if you're a neuroradiologist, you'll earn that income and the disability insurance policy. Other riders that you should add to your disability insurance policy include residual disability rider, inflation protection rider, and future purchase options so that you can increase your policy once you're an attending. As an example of how it's actually cheaper to be wealthy instead of not wealthy, once you become financially independent, you can cancel your policy and that'll save you money every year. Who do you buy insurance from? So there's 5 companies that sell disability insurance, and you have to go through an agent to buy these policies. So you want an agent that can sell you insurance policies from all 5 of these big companies. If they can only sell from 1 or 2, then they're not going to necessarily be finding you the best deal. So find 3 agents like this, ask them for a quote, and then just go with the least expensive quote. It's as simple as that. So next, we're going to talk about life insurance. So you want to have life insurance once you have dependents. Dependents meaning kids, a non-working spouse. There's several different types of life insurance products. The only good one is term life insurance. There's other products that mix investing with insurance, and these are typically more expensive, and the investment vehicles tend to be not as good and not as efficient as the other vehicles that we'll talk about in several slides. And you're typically not able to buy enough for what you need because it's so expensive. So I recommend only getting term life insurance, which just pays you a lump sum when you die, if you die. The amount that you need is personal. You typically want a lot to take care of your dependents. A good default amount might be $2 million. Some people consider if they have a working spouse to be their life insurance policy. However, you have to keep in mind that if you have kids and both you and your spouse die at the same time, then there will be no life insurance to pay your kids. And then also you can cancel this type of policy when you become financially independent. There's 2 other insurance products to be aware of. I don't think you need them as a resident, but when you're attending, you may want to buy them. The first is malpractice insurance. Some jobs offer this, some jobs don't, and some jobs offer it, but they don't offer enough. So you need to pay attention to this. And also umbrella insurance. So umbrella insurance basically pays you if any of your other insurance policies go above their limit. So for example, if you have a kid and they run someone over and someone sues you for a greater amount than your automobile insurance, then your umbrella insurance will kick in and cover that. Typically, residents don't have a lot of assets, so lawyers may not go after you as eagerly, but they know that attending neurosurgeons have a lot of assets, and they may go after you. Next is, we're going to talk about emergency funds, as well as high interest debt, which I consider a financial emergency. So you need an emergency fund. You need to have enough money in cash to pay for 3 to 6 months of expenses. You're able to pay for things that are unexpected, like car maintenance, broken air conditioner, medical bills. If you get fired and you have to relocate and find a job, it'll cover your rent. Typically, a resident's salary is very stable, so you can probably err on the lower side of this. Although you need to increase this emergency fund when you become an attending because number 1, your expenses will go up, and number 2, attending jobs are typically less stable than resident jobs. You want to keep your emergency funds in a savings account. You want it to be highly liquid, meaning you can get the money immediately, and you want it to be 0 risk, meaning having it be FDIC insured. The best options are high interest online savings account, like Affirm or Ally are good examples. Some people get concerned that their money sitting in a savings account is doing nothing. It's not making returns from the stock market, but this isn't the right way to think about it. You need to think about it as it's an insurance policy against you doing something stupid, which is robbing your nest egg. Typically, a lot of bad things all happen at the same time. So you may need your emergency fund when the stock market is doing badly, which is another word for bear market. So you would have to sell your stock shares during a bear market and lock in your losses, and that can be very devastating. So you don't want to do that. Have an emergency fund. I consider credit card debt and other high interest debt, anything above 10% interest rate, to be a financial emergency. So I think that high interest debt takes priority over filling your emergency funds. Pay it off ASAP. And the way to think about this is if you have 18% credit card debt, 18% interest credit card debt, this is and you're paying it off, that's an 18% guaranteed return on your investment. So if the stock market returns, historically on average 10% per year, and it's not guaranteed. This is a guaranteed 18% return on the investment. So that's a great bargain. While we're talking about credit cards, you can use credit cards to help you make money and also improve your credit rating. So to do this, you always want to pay off your full credit card statement on balance every time. And you can enable auto pay to do this so you don't forget. Finally, if you use your credit card with every purchase, you can be getting cash back or credit towards travel on every credit card purchase. I recommend having at least 2% cash back or more on whatever credit card you're using. It really bothers me when I see people, and I feel sorry for them at the grocery store or in the cafeteria line when they're paying for everything with cash, because they could be getting at least 2% back on all their purchases. But you keep in mind, you don't want to buy extra stuff because of cash back. That's just that's just math. Finally, paying your credit card on time helps you build a good credit history, and you need a good credit history to get a good mortgage interest rate or other loan interest rate. And then every 6 months, I recommend that you call your credit card company and ask for an increase in your credit limit, not so that you can buy more stuff, but just because one aspect of your credit score is the percentage of your credit limit that you have on credit. So if you have a very high credit limit and you only have $500 in your credit card at a given time, then that'll really help your credit score. So moving on to student loan plan. So having a student loan plan is extremely important. This can be a little bit dry, especially if you don't have student loans. So I promise we're going to talk about investing after this topic, but bear with me because it's a very important topic. So a lot of people should be considering public service loan forgiveness if you have federal loans. It only works for federal loans, not for private loans. The way that you get, so public service loan forgiveness, or PSLF, means that the government will completely forgive your federal loans tax-free. That's a huge deal. That's a great benefit. All you have to do is you have to make 120 payments, meaning 12 payments per year over 10 years, with certain specific payment plans, pay, repay, or IBR, at a 501c3 organization, which is a non-for-profit or governmental organization. So 10 years of payments with one of these 3 specific payment plans. Keep in mind that if your required minimum payment is $0, that still counts towards 120 payments. So a lot of interns have $0 minimum payments because they didn't make income last year, so they don't have any expected payments. And also during the CARES Act that was passed during the coronavirus pandemic, everybody with federal student loans has their loans in forbearance, and no one is required to make student loan payments. So every month of this pandemic until September, these $0 payments are counting towards your 120 payments. So if your goal is to go for PSLF, you want to pay the minimum amount possible because that maximizes the amount of forgiveness that you'll get from the government. So some specifics, of the 3 payment plans that I mentioned, repay is the best option for most residents. If your spouse is a high income earner, then I would recommend IBR, and you also probably should file your taxes separately. If you're doing repay, you want to switch to pay about 6 months before you become an attending. And the reason is because both pay and repay have 10% minimum income payments, but pay has a cap. So when you're an attending, you'll probably your required payments will be over the cap, so the cap will kick in, and you'll have to pay money as an attending. So there are rumors that PSLF is going away. All of these rumors are false. PSLF might be canceled for new borrowers who have not yet taken student loans, but in the master promissory note that you signed when you took student loans, PSLF was stipulated in your contract. So the government has a contract with you saying that you will have PSLF as an option. Okay, so don't worry about PSLF going away. People have successfully been forgiven with PSLF currently. So there is a track record. However, the company that runs PSLF, which is called FedLoan, is relatively incompetent. So it's important to save all documentation of your communication with them. So you can get this form, which documents the fact that you're making payments at a non-for-profit organization. And I would send this form to them every year. So every year when you recertify your IDR plan, send in this form to Fed Loan and save it, and that just proves that you're making qualified payments. That way, when you become an attending, you don't have to go back to Jackson and talk to HR, and just take care of it every year. If you're not going for PSLF, keep in mind that if you're going into private practice, for example, keep in mind that some hospitals, even outside of academia, are still 501c3. So PSLF could still be an option for you. If you're going into a job that is not at a 501c3, you probably want to refinance your loans to get a lower interest rate. But keep in mind, you have to be absolutely sure that you're not going for PSLF, because private loan refinancing permanently cancels the ability to do PSLF. So be very cognizant of that. So I recommend paying off all of your student loans within 5 years. If you have any more complicated of a student loan situation, or even any student loan situation at all, I think you should read this book. It's actually the only book written on the topic of medical student loans by Ben White, and it's actually a free download. So you have no excuse not to read it. So take a look at this book. Okay, so now moving on to what a lot of people consider the most interesting part, which is investing. So some people are afraid of investing. They're afraid of the stock market. They think it's too risky and it's not a good idea, so they just have a big pile of cash in their bank account. And they think that this is safe. And the reality is it's not totally safe. It's not safe from inflation. So every year, your money loses about 2 to 3% due to inflation. And while this could beat the market in a given year, it's very unlikely to beat the market consistently over a long period of time. So this is not the way to build wealth. I also want to clarify the difference between speculation and investing. Some people think that they're investing, but they're actually speculating. So speculating is when you are selling something that doesn't necessarily have any value to somebody else for hopefully more value in the future. So collectibles and memorabilia like Beanie Babies, baseball cards are an example of speculation. They're not really worth anything. You're just hoping to sell them to somebody else in the future for more. And then certain investments where you don't think the fundamentals of the company, but you just think that the company's going up fast are also considered speculation. The way that you know something is a speculation is it's a get-rich-quick scheme. Emotions are often involved. There's usually a frenzied behavior, herd behavior. Every single time that there's a big speculation, like tulip bulbs during the Dutch Empire, Beanie Babies, GameStop, we always see herd behavior, and people forget history, but history repeats itself. And the thing to remember is that eventually somebody will be left holding the bag. By the time you've heard about the speculation, it's probably too late for you, and you'll be buying in at the top. In contrast to speculative holdings, investments actually pay you to hold them. Investments are worth owning even if you never sell them. So unlike a Beanie Baby, if you held stock over years, it would benefit you to own it because it's paying you dividends. If you own bonds, it would be paying you interest. And if you own rental property, it would be paying you rent. So investments are different because they pay you to own them. So is investing during residency worth it? You're not making a whole lot of money now, and you're going to be making a lot more money in the future. It's definitely worth it. It's worth it for two reasons. One is it helps you build good financial behavioral habits. If you make it a habit to invest as a resident, it'll be natural when you're attending. Again, you want to hit the ground running when you make your first several big attending paychecks because those have the longest time to compound. And then it's not just worth it from a behavioral training aspect, it's also monetarily worth investing. As an example, if you make $6,000 Roth contribution, I'll explain in several slides what a Roth is, but if you make $6,000 Roth contribution every year for 7 years, and let's estimate that you make a 7% annual return, you can make almost $800,000 tax-free 40 years after graduation. So it could literally be $1 million decision to invest during residency. So in order to understand how to make money from investments, you have to understand sort of how the stock market works and the history of the stock market. So take a look at this graph on the left. So this is a graph of the S&P 500 stock market index from 1929 to 2020. And keep in mind, it's a log scale. So despite the Great Depression, the Great Recession, the Cuban Missile Crisis, World War II, the COVID pandemic, despite all of these horrible, horrible events, you see a trend. The trend is that the stock market over long periods of time tends to go up. In the short term, it goes up and down wildly, but over the long term, it tends to go up. And because it's a log scale, this is actually not linear growth, but exponential growth. This is illustrated a little bit more intuitively on the right. So this is a chart of the Dow Jones stock market index, which is a little bit different than the S&P 500. But over time, it's gone from down in the corner up to here. And I updated this slide last night. So as of last night, the Dow Jones was 33,730. So that's sort of somewhere off of the upper right-hand corner. So past performance doesn't indicate future performance, but I wouldn't necessarily bet against these trends, and I'll explain why in the next slide. But keep in mind that in the short term, the stock market goes up and down. However, in the long term, it tends to go up. The only way to make money off of this trend is to be a buy and hold investor in order to lock in your gains instead of your losses. So why is the stock market favored to go up in the long term? There's two reasons. One is that over the last several thousand years, humanity has experienced exponential economic growth. This is a picture that's hopefully familiar to a lot of you, looking at Moore's Law. So Moore's Law is the amount of computing power on a given transistor. And you can see that there's exponential growth over time. Because technology compounds over existing technology. You can use old technology to help you make new technology faster. And this combined with the exponential growth in the population size globally since the year 1000, that's partially because of increases in food production and also increases in technology. And every additional person on the planet is able to produce more goods and services, and they're able to use the technology available more efficiently in order to increase their productivity. So all these factors combine together to increase economic growth exponentially. The second thing to consider why the stock market tends to go up in the long term is that stocks are not pieces of paper. They are ownership shares of real living, breathing companies. And these companies want to grow and make more money. So they reinvest the money into themselves to grow. They do research and development. They pay dividends to stockholders. So these things together help fuel the long-term growth of the stock market. So when you look at these graphs, how do people lose money in something as exponential in growth as the stock market? How do you lose money in that environment? And the answer is fear and greed. And it's a problem of human psychology. So humans are very good at, we sort of evolved to live in the savannah. So if you see a lion, you should be scared and you should run away from the lion. If you see a gazelle, you should be greedy and you should try to eat the entire gazelle because you don't know when your next meal is going to come from. But this is the opposite of the behavior that you need to make money in the stock market. Fear makes people sell low during stock market crashes, and greed makes people buy high during bubbles, and the bubbles eventually pop. So it's very easy for me to sit here in my comfortable chair to just say this, but it's very hard to follow because when the stock market crashes, it feels like the world is literally ending at the time. Every single news article is about how the stock market is doing horrible. We don't know if we're going to recover. Remember 14 months ago when we weren't sure if civilization was going to survive because of the coronavirus pandemic? This is a very sad study, but this is a study from Fidelity, and they looked at the amount of people who sold all of their stocks during the coronavirus bear market. 30% of people sold all of their stocks. And why that's sad is because the people who sold their stocks locked in their 30% loss of their net worth, and they'll never get that money back. People who didn't sell eventually regained all of their money and continue to regain money now. So why does the news try to paint this picture of fear and bad situations? It's because fear and greed sell newspaper articles and magazines and clickbait. You're not going to sell magazines if you say, good news, there's exponential economic growth and we're all going to be fine. You sell articles and magazines if you say things are going to be bad. With this in mind, what is the most expensive phrase in the English language? This time it's different. It's not different. It wasn't different after the Great Depression or the Great Recession or the coronavirus bear market. We don't know what the future holds, but I suspect it will look something like this. About every 3 years, the stock market drops by 10%, and about every 10 years, it drops by 20%. But I believe that in the long term, it'll continue to go up. So just be aware of that.
And also be aware that about every 10 years, there's some sort of cataclysmic, horrible event, like 9/11 or the Great Recession. So in the next 10 years, I don't know exactly when it will be, but something bad will happen and the stock market will go down, but it will eventually recover. This is a fascinating study. So Fidelity, which is a brokerage company, looked at all of their investment accounts, and they found that the best performing accounts were from investors who were dead. That's unbelievable. In second place were investors who forgot that they had accounts. How is that possible? The lesson is that you should have a passive autopilot strategy for investing. Determine an investment strategy, write it down, automatically follow it until you reach financial independence. So this slide, I probably put too much information on one slide, but the summary of this slide is active investment strategies are bad because no one can predict the future. You can't do it and Wall Street can't do it. So buying individual stocks is likely a poor strategy. First of all, you should be focusing on neurosurgery. You shouldn't be reading about stocks. You should be reading about different approaches to brain tumors and different ways to do minimally invasive spine surgery. So that's first and foremost. Second of all, having individual stocks is not diversified. You've heard the phrase, you don't want to have all of your eggs in one basket. Don't put all of your eggs in one basket. And then finally, it's not tax efficient. Remember Albert Einstein's quote that taxes compound exponentially. When you are frequently buying and selling, you incur short-term capital gains taxes, which are the same high rates as your income tax rate. Whereas if you are a buy and hold investor, you're paying much more favorable long-term capital gains rate. So this is a boring looking graph that's actually really fascinating. And it says that of all stocks over time, 40% of all stocks experienced a catastrophic loss, which they defined as losing 70% or more of value and never recovering. So when you're picking individual stocks, keep in mind that you have a 40% chance of losing all of your money in a given stock. So maybe you can't pick stocks, but maybe you can pay Wall Street to pick stocks for you. And the way that you would do that is by selecting an actively managed mutual funds. But the thing is that the fund managers can't pick stocks either. A lot of times these fund managers they charge high fees for their actively managed mutual funds, and they're often very tax inefficient. They have a lot of buying and selling because they usually get commissions the more they buy and sell stocks within the fund. Even if you find a good fund manager, they typically can't beat the market and taxes and fees combined. This is another boring looking but fascinating chart. This is basically showing that of all actively managed mutual funds, 90% failed to beat their index that they were tracking. So you have to be very good at finding that 10% of actively managed mutual funds that won't fail to beat their index, which is also not possible. So what do you do if you can't do active strategies like picking stocks or picking an actively managed mutual fund? What can you do? Well, fortunately, Nobel Prize research conducted by Eugene Fama gives us the answer. The answer is index funds. So Fama came up with something called the efficient market hypothesis, which is that the stock market is so efficient that in the long term, you're not able to squeeze any extra returns out of it. So the only way to successfully make money is to track the market, to try to be as good as the market itself. So while it's very hard to beat the market, it's actually very easy to just track the market. And you do this with index funds that hold many different stocks and bonds within them. Index funds are highly diversified. The total stock market index fund contains all 3,600 publicly traded companies in the United States. So it's hard to get more diversified than that. They're very low cost. Some funds even have expense ratios of 0%, but very low cost, and they're also very tax efficient. They don't have a lot of turnover. So Mike Tyson, by the way, this is the same guy that went bankrupt after having $400 million, has a great quote that I love, which is, everybody has a plan until they get punched in the mouth. So you want to have a plan before you get punched in the mouth, because if you get punched in the mouth, you're going to panic if you don't have a plan. So pick a reasonable investment plan, write it down, and then blindly, automatically follow it. The exact plan doesn't matter, just stick with the plan. Don't try to time the market, because it's impossible to time the market, because we can't predict the future. And then finally, when you're investing lump sums, typically it's better to, typically more time in the market leads to better returns than dollar cost averaging. So typically it's better to invest all the money at one time. So in order to help explain how to make a good investment plan, first I just want to go over a little bit of background information, just basics of like what stocks and bonds are. So stocks are ownership shares of a company. They typically have higher expected returns, but they also have higher volatility, meaning they go up and down a lot more frequently in the short term. But over the long term, they tend to go higher. Bonds are loans to a company or a government, so not ownership, but they're loans. They typically have a lower expected return, but they also have a lower amount of volatility. They don't go up and down as much in the short term. So your portfolio, if it has more stocks, will have a higher overall expected return, but it'll have more volatility. When you increase your bond percentage, you are decreasing your expected returns, but you're also decreasing your volatility. So the amount of stocks and bonds that you have depends on your risk tolerance. So if you have a high risk tolerance, you typically want to own more stocks. So people with high risk tolerances are usually young people. If you're still in the wealth building phase, and if you don't read a lot of the news and you don't get freaked out by news articles that are spouting doom and gloom, people that have low risk tolerance include older people, people that read a lot of the news if you're very anxious, and also people that have either reached financial independence or have retired. So there's a saying which is, once you've won the game, stop playing the game. Once you have reached financial independence, you don't have to take as much risk anymore, and you want to increase your bond allocation to smooth out your ride. And I think that's true. You want to increase to at least 50% bonds once you reach financial independence. And then also, a lot of people tend to overestimate their risk tolerance. Everyone thinks that they can, they have a huge risk tolerance. But what I would recommend is if you are new to investing and you've never been through a bear market before, it probably makes some sense to have some bonds to smooth out the ride during your first bear market, and you'll see what you do. You'll see what your actual risk tolerance is, because if you sell stocks during a market crash, it means your risk tolerance is actually a lot lower. If you don't sell any money and you weren't really sweating it, then you may decide to decrease your bonds allotment and increase your stock allotment. So how do you pick a reasonable investment strategy? It's actually pretty straightforward. You just pick between 1 and 5 broadly diversified low-cost index funds. Typically, simpler is better because you make fewer mistakes. And then once you've picked your index funds, then you can just pick percentages to allot to each index fund. So how do you know which ones to pick? So Taylor Larimore, who wrote a book called The Boglehead's Guide to Investing, recommends a simple 3-fund portfolio. And that 3-fund portfolio is total US stock market. The US stock market is typically the highest performing stock market in the world. It is a very business favorable climate. He also advises including total international stock market index fund. So when you add the total international stock market index fund, you literally own every publicly traded company in the entire world. So it's literally impossible to get more diversified than owning every stock. Additionally, sometimes when the US stock market isn't doing well, the international stock market is doing well and vice versa. So again, you don't want to put all your eggs in one basket. And then the third fund of the 3-fund portfolio is total US bond market index fund. This has all of the corporate and governmental bonds in the United States. The other, fund that I recommend thinking about and only purchasing if you believe in this is a small cap value index fund. Retrospective studies have shown that companies that are small in size and undervalued tend to have greater growth than the total US stock market, but just by a little bit. And they're riskier and they have a lot more volatility. And it's only based on retrospective data, so keep that in mind. But I would say that the core 3 that you want to think about are total US stock market index fund, total international index fund, and total US bond market index fund. So if you're doing do-it-yourself investing, it just involves three easy tasks. Every month you buy additional shares according to your investment plan, and you maintain your percentages. So for example, if you have 50% US stock, 50% international stock investment plan, then every month you just take half of the money and buy US stocks and half of the money and buy international stocks. It literally takes 5 minutes every month. for the rest of the month, don't even look at your accounts or the stock market. During bear markets, again, which is when the stock market is doing poorly, there's two things that you can do to make money. One thing that you can do is something called tax loss harvesting. This is a way to lock in money, lock in losses on paper, but you're not actually taking money off the table. You're just switching from one fund to a very similar but, quote, substantially different asset for 60 days. And the IRS is okay with that, and they enable you to not pay as much capital gains rates. And you can read more about that if you want to learn more about that. The other thing to do during a bear market is to buy more stocks. It's interesting because when the mall when a store at the mall has a sale on pants, people go to the mall and they buy pants. But when the stock market has a sale on stocks, people sell their stocks, which actually is the opposite of what you want to do. You want to buy more when the stock market is on sale. And then the last task that you need to do is once a year, you should rebalance across all your accounts. So invariably, some of your investments will do better than others. So for example, this year, the US stock market did better than international stock markets. So if your goal is 50-50 US international, maybe currently you have 55% US stock, 45% international stock. So once a year, you would sell that 5% in excess of your goal of US stock and use it to buy international stock. This forces you to buy low and sell high, which is how you make money. And this has been shown to increase your returns. For people that really don't care about this stuff and it gives them a headache and they just can't be convinced that it's actually very simple and easy to do it yourself for investing, there's two great options for you. One is called target date retirement funds. These are great because they automatically adjust your stock bonds risk profile over time. So earlier on, they have a higher stock allocation. And then over many years, when you near retirement, they increase the bond allocation automatically. Another newer option is called robo-investing. Different companies called Betterment and Wealthfront are sort of the industry leaders with this. And they allow you to, they use artificial intelligence algorithms in order to help you automatically adjust your risk profile. You're able to pick and select your risk profile, and they also automatically do tax loss harvesting. So both of these options, robo-investing and target date retirement funds, have slightly higher fees than just doing it yourself, but it's worth doing them if you're otherwise going to do nothing. And they're still very good options. They have less control over your investments, which is both an advantage and a disadvantage. It's an advantage because it's less of a headache, but it's a disadvantage because you have slightly less control and you can't take advantage of certain aspects. So now we're going to talk a little bit about something that sounds complicated, but is actually very straightforward. So let's imagine that you're going on a trip. It's actually a trip and you're traveling through time. You're going from residency to financial independence. So when you arrive at financial independence, you want to have money with you so you can spend it. So the luggage on your trip is money. And you need a way to carry your luggage. You need suitcases to carry your luggage. So there's different types of suitcases with different qualities. So the Gucci and Prada suitcases are the tax advantage retirement accounts. And we'll talk about why that is in just a second. And then another type of account is the taxable account. So tax advantage accounts enable you to put money in them and let your money grow tax-free over your investing career. And it actually grows a lot faster in a retirement account. So this is a chart just showing that your money grows faster in a retirement account compared to a taxable account. We'll talk about a little bit about which suitcases to use because this can be overwhelming as well. I'm going to talk about two suitcases that are not really available to you at Jackson, but I want you to be aware of them because once you leave and become an attending, they may be available to you at those times. So the first one, we're going to talk about the employer match of a 401k, 403b. So Jackson does have a 401k, 403. Well, actually, it has a 403b because it's a not-for-profit. Nonprofits have 403bs, and for-profits have 401ks. But what they don't do is they don't offer an employee match. An employee match is when, for example, the employer says, if you put in $20,000 into your 403b, we will match that and we'll put in $20,000. And you always want to take full advantage of the employee match. It's part of your salary. If you don't do this, if you don't take advantage of this, you're leaving part of your salary on the table. So again, Jackson doesn't offer a match, unfortunately. And just to explain what a 403B is, so you basically take tax-deferred money, so you don't pay income tax on that money during the current tax year, and then it grows tax-free in your account, and then you finally pay taxes on it once you take the money out during retirement. So it usually makes sense for people with higher income tax rates, like attendings. The next suitcase that you can think about, which is not available at Jackson, but just be aware of it, is a health savings account. So this is a triple tax-free savings account, even though people don't think of it as a savings account. You put in tax-deferred money, the money grows tax-free during your investment career, and then when you take it out under certain conditions, you take it out tax-free. So it's hard to beat that. Unfortunately, it's not available at Jackson. So the first thing to think about that is available at Jackson is a Roth individual retirement account, or Roth IRA. So this is basically where you put in post-tax money, meaning you've already paid taxes on it this year. You put it in, and then you never pay taxes on it ever again. So it grows tax-free, and when you take it out during retirement, it's also tax-free. There is a 10% penalty for taking the money out early before retirement, but it's actually a generous policy, because you're able to take the money out to pay for certain things like paying student loans, buying a first-time house. So it really doesn't limit you a whole lot from that perspective. You shouldn't take it out early, but just in case you decide to not go for PSLF and you want to pay off your loans early, you can theoretically take out money from your Roth. The limit for a Roth is $6,000 per year. Also, if you have a spouse, even if the spouse isn't working, they can put in $6,000 as well. So I recommend, at the absolute minimum, filling your Roth every year. Next, you come sort of to a fork in the road. If you don't have loans, you can think about taking advantage of and putting money in Jackson's 403B. I took a look at the fund offerings, and unfortunately, they're very bad and they have very high fees. You can decide for yourself if they're something that you are interested in. The reason I'm saying if you don't have loans, you can consider is because if you put money in a 403B, I believe you cannot take the money out to pay for student loans, which doesn't affect you if you don't have loans. If you do have loans, after you filled up your Roth, just put the rest of the money in a taxable account. I'm kind of making fun of it here with like a beat up suitcase, but it's actually not a bad thing. Index funds are very tax efficient, so you're not going to be paying much tax anyway. And then it also provides something called tax diversity. I don't want to get into that too much, but when you're retiring, when you've retired, you typically want to have Roth money, 401k money, and taxable money. So this that helps you take out money more efficiently. So it is helpful to have some tax diversity during retirement. So I'm going to conclude with how to actually implement these goals. You need to make these goals with something. It's helpful to make SMART goals. So SMART goals are specific, meaning you don't want to just say that your goals have an emergency fund. You want to say, I want to have an emergency fund of $20,000. Okay, that's much more specific. You want to have them be measurable, so you can determine if you've succeeded or failed to meet your goals. You want them to be achievable, meaning you can't say I want $1 million in 1 year. You have to be much more reasonable. Reasonable goal would be saving 20% per year. They have to be relevant. All of the financial topics that we have discussed during this talk are relevant goals to your financial well-being. And then finally, they should be time-based, meaning that they put kind of some impetus behind you to actually do them. So if you say, I want to have a $20,000 emergency fund by January of 2022, then that would be a time-based goal. And that's it. There's actually a ton of phenomenal resources that are either free or very, very cheap that are online, and certain books they recommend. Dr. Wing's podcast has some great talks on these topics. And with that, I'll take any questions.